I'd like to welcome everyone to tonight's session on advanced wound care. I was challenged with presenting this, and I struggled actually in terms of writing a PowerPoint or a lecture on advanced wound care. And really because the word advanced is the difficult bit. Wound care is not complicated in the vast majority of cases. I just find it quite scary at times, and you see on the picture here, this is a traumatic wound from a dog fight, but it's all the more scary when that wound is large and it isn't closing, and it's a result of what you've done in attempting to remove a tumour. So we'll work our way through the principles of wound care, and I hope you all enjoy it. So, as we all know, most of my time is in general practice. Wounds are common in practice. Primarily, they fit into two categories. The first being those surgical wounds. And most of our understanding on wounds and wound healing comes from the clean surgical wound and studying the repair of the clean surgical wound. Primarily, those large wounds, those large wound defects are usually, in my hands, the result of oncology surgery, so particularly the removal of mast cell tumours. More and more commonly, I seem to be seeing these in practice. I'm not sure whether everyone else is feeling the same, but we're able to do much more now. The oncologists have done a great job in developing things that allow us to do much more, and that's really why we're now starting to see large wounds to repair. And the second is obviously the major traumatic wounds. Just 2 weeks ago, I saw a wound that measured just over 20 centimetres along the side of a cat, which was unfortunately 10 days old. So we do see these traumatic wounds as well. As we know, a wound is the interruption of the continuity of that external surface of the body or of an internal organ. And it's that disruption in normal, that absence of a normal barrier, which is what we obviously classify as a wound. It's important to remember with wounds that as much of the challenge of dealing with a wound is often dealing with the fact that there can be prolonged healing times. All too often, I think, we kind of see a wound and we immediately wish to close it, and we immediately wish to deal with the wound there and then. And we shouldn't be frightened to consider a wound a challenge that may take us several days or even several weeks, rather than something that needs to be done immediately. And in order to have success, as with everything we do these days, those prolonged sort of healing times and expense and the distress of it just pushes us right back to considering how we communicate with the client and how we look after the patient. Many large wounds may require repeated sedations. We all have our preferred sedations, or indeed in certain cases we might need to consider general anaesthesia. So really at the acute onset of the wound, it's very important to really focus on communicating with the client and ensuring the client is fully aware of the likelihood, in a major wound, that this can't be or won't be dealt with in one hit, so to speak. Back in the tail end of last year, I removed a cutaneous grade 2 mast cell tumour from the base of a tail in a Labrador called Fred. The tumour removal itself was relatively simple, but we knew we weren't going to be able to close that wound. And the success really there was not in the picking up with a scalpel blade, but in the communication with the client, getting them on board that this was going to be a process that maybe took 6-7 weeks and needed time and needed patience. And I think it's always important when we're looking at wounds to make sure that we do get client compliance, and that's so important with everything now, is to manage those expectations. Wound healing, very simply, can be defined as the restoration of damaged tissue to normal tissue. And what we're trying to do is repair the issue. We're trying to make it as normal as it was before the event. Now, invariably, we never get it as normal. It's always potentially a weak spot, but the aim is always to do that. There's some really good papers in Practice, which for anyone who's got an interest in wounds and wound healing, I would advise to have a look at and have a good read over by Anderson. And in that paper, she lists the aims, which I think are fairly accurate, really, of wound healing to be functional repair, cosmetic repair, relief of pain and distress, the fact that the wound must heal economically and time efficiently, and there must be a quick response from our side if there is any delay or failure to heal. My personal aim often is not to heal the wound. I'm very much a believer in managing the environment, so I'd much rather allow the environment to be as optimal as possible for healing. And what that means is managing everything so the body can do its job and nature can do its job. Excuse me. In terms of bandaging, bandages are something I don't use all that frequently. I'm more of an advocate of open healing where possible, although in all cases that's not always the situation. But it's all about managing that environment, trying to make sure that the body, nature, the fresh air, all those things that we want on our side are working for us rather than against us. A bit of a throwback, really, when I was writing this presentation to when we were studying. It's obviously the key to providing that successful environment is to understand the principle of wound healing. And wound healing occurs in three broad phases. The first being the inflammatory phase, which usually occurs in the first 72 hours. The proliferative phase, which can occur between 3 and 7 days. And then onwards, the remodeling phase of 7 days onwards. Now, as you know, these phases are not discrete entities. They are an overlapping process. And the overlapping process can also be amended or changed by changes in the environment. So we won't get movement into the remodeling phase from the proliferative phase until the proliferative phase is relatively successful in achieving its aims. I'm not an immunologist, so just at the bottom there you'll see a nice reference, which is the Hosgood paper from the Veterinary Clinics of Small Animal Practice. In 2006 they produced a series of articles on wound healing, which again provide very useful references. I tend to have the vast majority of the papers regarding Anderson and also the Hosgood papers just in a small folder in the prep room in a practice, so that if I do get anything a little bit out of the ordinary or we just want to confirm anything up, then that is available to us. Anyone with the appropriate memberships can get these online now and hold them on iPhones or iPads if that's preferred. Wound healing basically can be summarized in the following way. So you get an injury, whether that be traumatic or surgical, and at that point you then get the formation of a clot. That clot can then obviously be, for sort of focus into chemotaxis, and following on from chemotaxis you get the invasion of macrophages and then subsequently proliferation. Alternatively, the clot or the injury can literally return to epidermal cells, and then wound closure can be achieved. Now, wound closure can be achieved in a series of ways, which we'll go on to later on in the PowerPoint, but that can, in broad terms, be closed, or you can look after the wound, clean up the wound, provide a healthy bed like a granulation tissue, and then close subsequently. So again, it boils down to the fact that wound care doesn't necessarily need to be advanced. It just has to be brave. It's not a case of I must clean and clear this wound today. It must be closed with immediate effect. So if we start looking at the inflammatory phase, the inflammatory phase in its early stages, the first couple of